Hello there. Okay, so let's get this lecture on suicide going. Here you can see this week in psychiatric history. 1989, the antipsychotic drug Clozaril was approved by the U.S. Food and Drug Administration. So remember, that was a drug that was approved back in the 70s, taken off the shelves because it caused so much harm to people, and came back in, and it still is today, and it proves to be a very powerful and effective antipsychotic, but it does have dramatic side effects that we have to look out for as protecting our patients. Okay, sorry that took so long to figure out what I was doing here, but we are going to talk about suicide. And here is a slide that states no one really wants to die. There is always a key. This came from an SOS, which was Stamp Out Stigma, who turned into Seeing Through Stigma, presentation of 1997. And if you look through these slides, you will know exactly what that means in terms of what is the key. And here it is. It means that no one person who is in that much emotional pain really wants to die. The person just wants to depart the pain and anguish being experienced. Finding the key is essential in helping the suicidal person begin to unlock the pain and embrace the hope. And as nurses, that's an important intervention in terms of our therapeutic communication, is to find out what's important for them, for what is important to live for. And we will venture now into a YouTube 5-minute video regarding a patient who, or person who actually survived jumping off the Golden Gate Bridge. Bear with me while we get this on. Okay. And here it comes.
We're giving away prizes, cash, and cars at Great Resort and Casino. Win a Nissan 370Z Roadster or your share of $30,000 in cash, guaranteed. Drawings are the last Friday of July, August, and September. The Road to Riches giveaway.
Okay, we don't need to see that ad. Here we go.
We have lost far too many lives traveling the path to this day.
Since 1937, over 2,000 people have died at the Golden Gate Bridge. I feel lucky to be alive every single day. Of the thousands that have died off the Golden Gate Bridge, I am of the 1% who have survived. So I was born on drugs and premature, and then I bounced around from home to home. Nobody wanted to keep me because I was sick, and I got lucky. I landed in the home of Patrick and Deborah Hines. I had a great childhood. I thought, growing up, that everything's going to be great. And then at 17, it all came crashing down. If you can imagine feeling that everyone around you is out to get you, trying to hurt you, and trying to kill you, and you believe that to be the truth. From the extreme paranoia, I exhibited symptoms of mania. From the mania came the hallucinations, both auditory and visual. And so with that and the bipolar disorder, I just was spiraling out of control. I vividly remember writing my suicide note. People don't get it. Like, I thought I was a burden to everyone who loved me, because that's what my brain told me, because that's how powerful your brain is. I got off the bus. I walked slowly down the walkway of the Golden Gate Bridge. You know, people rode by me, drove by me, walked by me. And a woman approached me, and she said, "Will you take my picture?" She said thanks, and she walked away. It was that moment I just said, nobody cares. The reality was that everybody cared. I just couldn't see it. I ran forward, and using my two hands, I catapulted myself into free fall. What I'm about to say is the exact same thing that 19 Golden Gate Bridge jump survivors have also said, the millisecond my hands left the rail, it was an instant regret. And I remember thinking, no one's going to know that I didn't want to die. In 4 seconds I fell 75 miles an hour, 25 stories, and I hit the water. I was in the most physical pain I had ever experienced. I have ever experienced. The Coast Guard was amazing. He was just so freaked out that I was alive that he just dove in and brought me on board. The guy said, do you know how many people we pull out of this water that are already dead? And I said, no, and I don't want to know. The guy put his hand on my forehead and said, kid, you're a miracle. My father took one step into the hospital room, and I looked up at him and I said, Dad, I'm sorry. And he said, no, Kevin, I'm sorry. And if you think about it, both of our immediate reactions were guilt. Guilt that didn't belong to either of us. And even though I didn't die, I caused people a great deal of grief and pain. Just the day of my attempt still sits within them today. I asked my father if he still feared my death by suicide. He said every time the phone goes off, his first inclination is Kevin alive. I had that impact on my dad. So after the jump, the road to recovery was pretty long. I had 7 psych ward stays in the next 11 years. I still have all the symptoms I ever had. Mania, depression, psychosis, hallucinations, all that's still there. I just know how to cope with it and I know how to beat it. I built a support network over these years of treatment so that I wouldn't be fighting this alone. So like, it's okay not to be okay. It's not okay not to ask for someone to back you up. To the families who live with the loss or losses of loved ones, they didn't do that to hurt you or destroy your life. They took their lives because they were struggling and in a great deal of emotional and mental pain. Suicide, mental illness, and addiction are the only diseases that we blame the person for perpetually. But people die from suicide just like they die from any other organ diseased. Today, no matter the pain I'm in, no matter the struggles I experience, I do believe that life is the greatest gift we've ever been given. And if you're suffering mentally, don't wait like I did, sitting in denial for so long. Because recovery happens. I'm living proof.
Wow. That's impressive. Okay, moving along. Something to think about. All right, so back to this reality. Considering the transactional model, where is suicide? Where is that along the anxiety continuum? Yep, it's up there at panic. And Kevin, boy, was he an example of that in terms of bipolar disorder, which we just discussed, and panic level, where somebody experiences hallucinations, in which we're working on in Skills Lab, kind of getting an understanding for that. Wow. Okay, suicide is not a diagnosis or a disorder. It's a behavior. Someone seriously considering suicide would fall more towards the panic level, as I said. And when somebody's ready to act on the thoughts, their anxiety will reduce. They will look really calm. That's a key feature. Approximately 95% of the suicides are by individuals who have a diagnosable mental disorder. All right, men, this is your diagnosis. As the previous ones and ones that go forward, we'll see more women suffer than men, but men tend to die by suicide more frequently than women. That gender ratio is 4-1. 73% of all suicide deaths are white males. 80% of all firearm suicide deaths are white males. This is going to ring very true when we start looking at the elderly, which is the next lecture. Among the highest rates, when categorized by gender and race, are suicide deaths for white men over 85. Again, coming up in the next lecture. these individuals had a ratio or a death rate of 59 in every 100,000. This is an interesting graphic here, looking at different countries in the world in terms of males versus females in suicide death rates. And as we can see that the rural area of China, more females than males commit suicide. And, some thoughts about that might be that there's no support system there. That country in general doesn't offer a lot of support in terms of mental illness and suicide, but in a rural area that tends to, there's not a lot of access to healthcare, mental health care in general. But anyway, you can just kind of pause and take a look at this graphic and see where the suicide rates are. And Lithuania and Russia, Estonia, these are all your Slavic and Russian Soviet type countries. And, what do we make about that? I don't know. Anyway, take a look. Okay. Moving along. And if we look down at the very bottom, I'm just going to pause and say one more time that there's Greece. Maybe that's the country to move to. Okay, here we go. Another interesting graphic to look at in terms of age groups, in terms of gender, in terms of just comparing black versus white males and females. And to look again, talking about where's the highest rate. And I'm going to take the cursor and come right around here looking at 85 plus. This is your white males. Okay, here's another peak. Where's that? Black males. Here's the age group, 20 to 24. What kind of stressors are going on there? Another peak for that gender and that race, 70 to 74. And then looking along the very bottom rung here of this graph, right there, that's your black females. A little something about resilience, dealing with stressors. We can learn some things maybe. Okay. So stats within the National Institute of Mental Health, you can read those. 11th leading cause of death, 7th leading cause of death for males, 16th for females. 3rd leading cause of death among people ages 15 to 24. So that's a higher age group, or age group that has a higher suicide rate. Following unintentional injuries and homicide. It's kind of startling when you look at that. Unintentional injuries because risky behavior. There are an estimated 12 to 25 attempted suicides to one completion. The ratio is higher in women in terms of attempts and youth versus lower in men and elderly. So men and elderly tend to complete. More women than men again report a history of attempted with a gender ratio of 3 to 1. Finally, firearms are the most common method. Professionals have higher than average suicide rates, and some American Indian tribes have rates 5 times the national average. African American women and adolescents, however, we saw that graphic of African American women, their suicide rates are climbing. Respectively, African American women, 80%, whereas 200+% over the last 20 to 25 years for adolescents. So that graphic, I believe it was around 2010 or so. So it said 80%, 200+. So they're probably still steadily rising. There are common stressors. So again, looking at the transactional model, it talks about stressors that cause anxiety, and anxiety, how we escalate up the anxiety continuum. So usually a stressful situation precedes an attempt. It doesn't come randomly. There's something very stressful that happens. Some of those stressors would be divorce, rape, death of a significant other, illness, legal problems, financial problems, and illness of any sort. Loss of great magnitude. That's a huge one there. So maybe, subsequent losses or loss after loss after loss cause, the person to potentially look at suicide as an option. So when we look at our elderly and elderly males, there you go, there's a validation for that. Difficulty with forming or maintaining relationships. So BPD, not bipolar disorder, sorry. That would be your borderline personality disorder. And those individuals have a great potential for suicide. A lot of times it's just attempts, it's just a cry for help, it's a gesture. But sometimes by mistake, they did not mean to actually complete. They failed to get the message out and they ended up dying from that. And our guest speaker, Christopher Jump, will talk about that. He can easily relate to this because this is his life. Or was his life, I should say. His life is much improved. Some are sensitive to loss, so sometimes we just are more sensitive to loss. Some people are more sensitive, having maybe coupled with insecure or unreliable in terms of feeling supported childhood experiences, and therefore they are more apt to contemplate and then commit suicide. So what are our theoretical perspectives? Of course, there's the biological and alterations in serotonin and other neurotransmitters, basically a decrease in the excitatory. The question also is genetics versus learned behavior. Is it genetics? Does it run in family, or is it just these gestures and children learn from them? Psychoanalytical, and what did Freud think? He, again, remember, gave us many of our ego defense mechanisms and thought of this as being a repressed desire to kill someone else. Murder in the 180th degree. A wish to get rid of the hate itself or to be at peace with the internalized person. Other factors. Developmental stressors. Maybe that answers the question of why teen suicide rates have increased. There's always a thought that, what it means to be a teenager these days versus in previous years. And it seems like with every decade, it gets more and more stressful. We're looking at currently with teens going through, using electronics and what have you, and the bullying that goes on with that. And it's just very stressful. Maybe. Okay, middle age, those with chronic medical conditions. They just can't take it, especially when they're looking at chronic pain conditions. History of violence and aggression. What about humiliation and shame or guilt? Researcher Durkheim's 3 social categories of suicide include egoistic suicide, where one doesn't feel part of a group, family, or religion. They just don't feel like they belong. I think when we look at the words or hear what Kevin said in that YouTube video, he didn't feel a part of anything. He didn't think he was supported. He didn't think anybody cared. Of course, he also had some pathology going on there with the bipolar disorder. Altruistic suicide. Sacrificing one's life for a group or a cause. And wow. Terrorist. And what about anomic suicide? Something where there's a change in life. Maybe that's a loss. Something else. resulting in feeling no support from anyone. So these tend to get overlapped with psychological views, and I say don't get too focused here on the actual type or why. There's just a lot of studies in terms of how people contemplate and commit suicide and why they do. There's many different reasons, and then so researchers just basically study this and put their own titles to that. One that's not in your textbook that I know of, that another researcher, and it escapes my name right now, but talked about ludic type of suicide. And ludic meaning that people take great risks where they don't really care, or they do care, but the risk, the thrill is greater than the actual idea that they might hurt themselves or even kill themselves. So people that do very risky type sports and what have you might be in fact ludic. So we look at that from lunacy, ludicrous, persons that do things without much judgment or thought. Okay, in terms of the nursing process, definitely you're looking at some things here. And when somebody is talking about harming themselves, making statements like they don't want to live anymore, we need to ask them very directly. That is the question you have to ask right away. Are you thinking of hurting yourself? That's just one phrase, but we have to go right out there and ask them. And then once that person responds with, yeah, I'm thinking of it, then we want to know, what is their intent? How serious are they about that? Are they just thinking about it? Or they actually have a plan? And if they have a plan, it's what type of lethality is behind that? Is the plan to maybe take a handful of Advil, which will definitely upset your GI tract, but will it actually kill you? Probably not. So we look at lethalness, or do they actually have a gun? What is their mental state? So considering level of anxiety, if somebody's really, really anxious and panic mode, you can see that they're less likely to actually follow through. They can't focus. Somebody who's extremely depressed, who can't even move because their neurotransmitters are so depleted. We're worried. Don't get me wrong. We're concerned. But it's the person that gets down to that mild level of anxiety who is most apt to actually follow through with the suicide attempt or complete it. We have to determine who are their support systems, who's out there to support them. Remember, this person is very depressed, it feels absolutely like nobody cares, as Kevin said, and can't even see that they have a support system. And then what kind of other coping strategies have they used? Are they using other methods of coping that are not adaptive, that are actually maladaptive, like substances and what have you? So there's our assessment in terms of what we need to determine. There are suicide indicators, behavior changes, any behavior change. We're really looking at that. This is really important when we're looking at children and adolescents. Level of anxiety, I just talked about that. Poor concentration, despair, anger, anorexia, insomnia, calmness. Again, that calmness can be very, very scary. They're so good at covering up. Risk periods. So there are some actual risk periods in which we might think that somebody is more suicidal. Holidays are the number one, especially if there's nobody around to celebrate with. This is when people will tend to pick up more substances and alcohol and drink themselves to death, essentially. And so we look at support groups and knowing that AA is open 24/7 around Christmas and New Year's for people, just to address that, because they have exhausted their support systems. They have no support system. So holidays, feeling sad around that time. Springtime, lots of thoughts along that line. There are theories that it's, allergy season, and are there allergies that are actually influencing one's neurochemical imbalances? Is it tax season? There's lots of different things, the thoughts. But springtime is statistically a higher rate of suicides happen at this time. On the nursing units between 10 a.m. and 6 p.m. It's really busy during those times. So nobody's paying attention. We don't have time to check on that patient. We're so busy. Another time would be during change of shift, because again, we have a staff that's tired and going off shift, and a staff that's trying to hear report, and there's not a lot of supervision. What about the family or significant others? Is it appropriate to ask for their input? You betcha. Of course, we have to really look at HIPAA for that and make sure that we have that permission. But to get their insight and what they're seeing, that's really, really important. Don't forget your own feelings. If you've had experiences with loved ones or friends who have completed suicide, and that's gonna come up. It's gonna run through your head. It's going to change the way you present towards a patient. So check in and understand what your own feelings are and recognize those. Okay, so nursing diagnoses. The top number one risk for suicide, and even though it's an at-risk or risk for nursing diagnosis, it is the priority. Hopelessness. Extreme hopelessness. And again, thinking about Kevin and how he, what he spoke to, hopelessness is there. And ineffective individual coping. What's it related to? Depressed mood. You can't say depression, but depressed mood. You can say that. As evidenced by, where do you get this again? Looking at your assessment. Subjective, objective, what's going on with that patient. Your short-term goal is to have the patient remain safe and contract. They may need a one-to-one, meaning a one-to-one in terms of security, or a staff member with them if they're on the unit, somebody with them at all times. The long-term goal, as the patient stabilizes, the patient will begin to list some coping mechanisms, maybe 3, maybe 2, maybe 1, maybe 4. Set a realistic number. Name at least 2 support people. 1 support person, 2 would be better. State that they want to live. And name an alternative, 1, 2, 3 alternatives to suicide. And that would be an emphasis on focusing on the resources that are out there in that person's community. Interventions, address the crisis. What's going on? What precipitated this event? Do not leave the patient if they continue to voice ideation and intent. And if they do, you need to get somebody to sit there with the patient. So it doesn't mean necessarily for you to stay there all the time, but to assign a staff member in terms of that one-to-one. Mobilize coping skills. This is when they're able to think about that, when they're coming into a time frame of really being able to cognitively put this together and think of the different coping skills they have. Assess the need for hospitalization if you're out in the community as a home care nurse or a clinic, or if they're in an emergency services area of the emergency room. And if hospitalized, follow the therapeutic guidelines that are laid out on that unit in terms of suicide assessments and in terms of what type of interventions are appropriate. This may involve the patient not having their own clothes, wearing a hospital gown. Maybe they're under constant surveillance via camera, via insight of the staff at all times, contracting for no harms every 15 minutes, every hour, every shift, whatever it fits for this patient. In our therapeutic communication, we're going to be supportive and demonstrate genuine concern to make those statements that it's important that this person live. Find those keys and build upon those as strengths. And again, establish the contract, a no harms contract specifically. Help this individual increase their decision-making process because, again, they're at panic level at times and they're not able to think through. We're protecting this person. And again, offering community support. Talk about what's available for them in their community. The suicide hotlines are very, very important. And then your evaluation. Did the patient remain safe? Coping strategies. Were they there? You know, what kind of coping strategies did that patient come up with, or what did you talk about? What was the outcome there? Plan to remain safe in the community. You can't follow that patient home, so you have to really ensure that they have good support out there. And document everything. You need to really, really document everything that's going on with this patient in terms of their behaviors, behavior changes, and seek intervention as quickly as possible if they are making any type of gestures towards suicide. All right, I think we're done.